Hello, everyone. My name is Terry James Taylor, and I'm with Montgomery Hospice and Prince George's Hospice. I'm the Director of Community Outreach. I've been working with Montgomery Hospice for a little over 17 years now, and we are a nonprofit organization that serves both Prince George's and Montgomery County residents. And we're happy to be able to share some information with you, just general information regarding hospice care. Today we have three of our team members who is going to share some information that's pertinent to COVID-19, in addition to how we will work with you in the community in a facility setting and in independent living settings. I'm going to first start out and have Trayvon to introduce herself, and then we will go to Catherine, and then last but not least, Atande.
Okay. Hi, everybody. I'm Trayvon McLean. I'm a licensed social worker. I work on the Prince George's County team, and I work in Prince George's on the Amber team.
My name is Catherine DiFrancesco, and I'm a clinical manager at Montgomery Hospice and Prince George's Hospice, and I'm a registered nurse and certified in hospice and palliative care.
My name is Atande Defan, and I'm a clinical nurse manager here at Montgomery and Prince George's Hospice.
Okay, well, as we get started today, Atande, I'm going to ask the question to you. What is hospice?
So it's exciting to talk about hospice. Hospice is a specialized model of care for patients facing a life-limiting illness with a prognosis of 6 months or less. You know, this care model helps us to support the patient and the family and the caregivers. It is a model of care that doesn't focus on the illness. It does focus on the patient, on the person. It involves a dynamic group of needs, such as physical needs, spiritual needs, psychosocial needs. So that's what hospice is all about.
Okay. Now, Atande, who is eligible for hospice?
So patients facing a life-limiting illness of 6 months or less, as certified by 2 physicians, are eligible for hospice.
Okay, and Catherine, do you want to add to that?
Sure. You know, as Atande said, a life expectancy of 6 months or less, if the disease were to run its normal course, is one of the criteria for hospice. But such a prognosis is only a prediction, and it doesn't mean a person will die within 6 months, because everyone is different. If the patient lives longer than 6 months and there's no improvement in their condition, or they continue to decline, then after that 6-month period, the physician could recertify the patient for an extended period of time in hospice. But some of our hospice patients do get better. They do get healthier, and they graduate from hospice. And if they were to graduate from hospice, then if they were to decline at a later time, then they would be eligible to come back to a hospice program.
Okay, that's good. That's really good information to know, because I know sometimes, I'm sure that you all have run across families that wanted to know, well, what if they get better and they start declining? Can they come back? So you answering that really clear is very helpful. And Catherine, tell us who's eligible for hospice.
Hospice is for anyone of any age with a life-limiting illness that meets the criteria. The criteria starts with the medical director of the hospice that the patient is referred to, and their community physician, oncologist, or primary physician, whichever physician that the family and patient chooses. And what those 2 physicians are looking for eligibility is that you have a life expectancy of 6 months or less. So.
Okay. How can hospice help residents and include what services are part of the program? If you could share that information with us, Atande, that'd be great.
So how hospice can help residents is fantastic. It's truly beautiful what we do. You know, we are available to serve residents and patients in any place of residence, be it in their homes, be it in assisted living, be it in a nursing home. We're available to take care of patients who have life-limiting illnesses at in any of these places. We do provide, you know, we have a team, and our team is our interdisciplinary team, which includes a nurse, a social worker, a chaplain, a volunteer coordinator, you know, a hospice aide. We have all this, you know, resources available to the patient and the family. Not only, you know, one of the other beautiful things that we do is the services that we offer with our volunteer department, which include, you know, complementary therapists of all sorts. So we can definitely serve residents in any of these places, meeting them at their own very need in the special ways in which the residents or the patients and the families need us, by providing them the services to foster comfort and to foster, you know, peaceful end of life care.
So adding on to what Atandi said, the hospice care team coordinates the ordering of delivery and setup of all necessary medications, hospice medical equipment, hospice supplies. They work with the patients and the caregivers and the facilities to make sure that everybody knows how to use their equipment, their supplies, and medications.
Okay, that's good. And Catherine, give us a little bit more detail on the disciplinary team. Say, for instance, give us an example of what one of our home health aides, when they come into a community, what some of the things that they may do along with the chaplain.
Okay, sure. So for a home health aide, they work under the registered nurse's plan of care. So a nurse would come out, they assess the needs in the home with ADL care, which is activities of daily living. So the home health aide would help give a bath. They would help with feeding if that was what was most necessary for the patient. So they help with dressing, feeding, bathing. Those are the typical kind of activities that a home health aide would help with. And they come and service a family as needed per the plan of care with the patient, but it's typically an hour up to 2 hours, a few days a week is a typical home health aide schedule. With counselors, bereavement counselors, social workers, chaplains, they all have their individual degrees and certifications to support within their discipline. So for a chaplain, they would be offering spiritual care as to your need. They also can help with finding some community resources. So if you needed support through your own church but was having a hard time being able to contact them, they would be able to help do that contact with your church for you and get them in. So every discipline has multiple services.
And that's really good to know right now during COVID-19, because so many people are not able to get out into the community and go to church with the distancing. So a phone call from a chaplain can be very helpful right now. So Atande, a lot of times people want to know if we have 24-hour care. Could you share with us, Atande, if we have 24-hour care or not? And if so, if we do or not, share how we handle our 24-hour services.
Okay. So in Montgomery and Prince George's Hospice, we provide 24-hour care to be available to our families and our patients for, you know, in the ways that they may need us. But we do not have people sitting in the home caring for the patient 24 hours a day. But we are available to the patient and the family should there be a need, should there be a symptom management need, should there be a teaching need, whatever need it is that the family may need or the patient may need, we are available. And so, you know, so this is how we do provide 24-hour care to the patients and the families, but not to be at the bedside of a patient 24 hours a day.
Right. But Catherine, in the event if a family member calls at 2 in the morning and is really needing a visit, will Montgomery Hospice and Prince George's Hospice provide a visit?
Absolutely. So we have a triage team. They call in. When they call that triage team, that nurse will assess if it's a need that is emergent that the triage nurse can't answer by the phone. They absolutely will send a nurse out to the home to ensure that the patient is safe.
Okay. In this part of the segment, we're going to move a little bit to advanced care planning. So, Trayvon, I have a question for you. Share with us what is advanced care planning? Why is it important to have one now more than ever?
Okay, so advanced care planning and a advanced directive is it's a legal document that specifies what actions a person would want to be taken with their health if something would happen to them, like if they would become ill or incapacitated and they could no longer make decisions for themselves. And so it's very important right now, especially during the COVID and the pandemic, that a person does specify or shared with a loved one or a family what they would want done for themselves, especially during this pandemic, so that their family or their loved ones would know what to do in case they couldn't speak for themselves.
Okay. And what if they do not have an advanced care directive? What if they don't have that?
So if they don't have one, hopefully they've shared with somebody, what they would or would not want done. If they haven't, this would definitely be a time for the families to come together, look if they had a will, if they didn't have a will, start that discussion, revisit it if like they had a will, maybe make some changes. If not, kind of think about, the person's situation and the quality of life. So this is a great time to start thinking about those things and the situations. And always you could get those things in place, with the help of a social worker or somebody can help you guide you through it. Those are some of the things that I do assist with as a social worker in hospice. But this is a great time to start having those discussions.
Okay. And I know a lot of questions can arise when it comes to, can you still qualify for hospice if you have a DNR or if you do not have a DNR? Share with us a little bit of information about that when questions like that arise.
So in order to be in hospice, you do not have to be DNR or code status. A person could have full code status and still be in hospice. So that is a good question, a great question. So it's important for patients and families to know that. And one of the things that is very important is to kind of talk through that process and decide what's best for that individual, that family. And when I'm talking with the families, it's important to make sure they understand, what they're deciding and what they think is best for them. And I try to make that process as easy as possible. It's a lot of medical jargon, but the main thing is to kind of help them through it and make sure they understand the choices, and kind of take that medical jargon away and just make it as simple as possible and just guide them through the process.
Yeah, because I know it can be very overwhelming, especially when it's a time that you have to make a decision to even come into our program. Right. And Kathy, many assisted living and senior communities are implementing lockdowns due to COVID-19. Can the Montgomery Hospice and Prince George's Hospice patient team, what is the protocol for going into such facilities and communities?
So the good news is that the hospice team can still make visits in facilities. Every facility has their own protocols, and so we do everything to ensure that we're meeting the facility needs as well as the patient's needs during this time. So we typically will call each individual facility and find out what is their protocol. And with that, it means, are we just coming with a symptom management need, or are we making regular visits? But what we are doing is making sure that we meet the needs of the patients in those facilities with great communication with the nursing homes and assisted living. So it has worked out. It is different. We do wear our personal protective equipment. We do everything to ensure that the staff in the facility, the families and patients and our staff are very protected. And with that, so far it's gone well. We've had great collaboration with the nursing homes and facilities.
That's good. Do they ever call us and ask us what our protocols are, or if we've ever been turned down because it's on complete lockdown?
So yes, there are times that we've had nursing homes, like I had a facility that was assisted living that went into a complete lockdown and did virtual visits for a few weeks. But then they recognized that the hospice team was needed, and they definitely let us in to do those symptom management visits to support their patients. So they're really doing an excellent job, even in the complete lockdown, to try to make sure that we're always taking care of patients that are at the end of life and that we're supporting. So the good news is, one that is in a total lockdown, they're making sure there's a virtual visit or some way to have communication with eyes on the patient so that we can collaborate even by phone.
Okay.
And through this virtual apps to help the families and patients.
Okay. And I know, Atande, COVID-19 is such a scary situation, and there have been, as we very well know, a lot of people in the community that's dying from it. But I'm sure a lot of people want to know, do they automatically become eligible to have hospice care if they are COVID-19 positive?
That's a wonderful question. And the answer is no. Being COVID positive doesn't mean that you're dying. Doesn't mean that you're going to die in 6 months. But what happens is, should someone be COVID positive and have, other underlying conditions that make them compromised and put them at a state where disease has progressed, or COVID-19 rushes the state of their other disease progression that makes them possibly to die in 6 months, they are eligible for hospice. If someone is COVID positive and has distressful symptoms, is unable to breathe, is all the other things that being COVID positive does, how it affects us, then that person is definitely eligible for hospice.
Okay. Kathy, how often can someone be seen from hospice staff?
So hospice follows each individual patient and family needs. So you could be seen every day, you could be seen once a week or every other week. It really goes by the patient and symptoms. That's how we are guided by our visits. So depending on the individual need is how frequently you will see your nurse.
Okay, and one more question to you, Kathy. Is it different now that we're in this pandemic when it comes to visitation?
It is. It's different, not in the fact of meeting the needs, but it is different in the visits. So again, we really are out to make sure that we are protecting patients and families. So we are doing a lot more virtual and telehealth visits at this time. They've been actually very effective, and we've really been able to meet the needs of our patients and families doing that. We still come out for symptom management visits, and again, it also does not change the hospice philosophy of individual patient and family goals of care. So if there's somebody who has symptoms that are not being managed, we are going to go out there and see that patient until we manage those symptoms. If they are able to do the virtual setup and they're comfortable and they say we would prefer to not have you in the home, then we can do that and still meet their needs. So
Okay.
even in the time of COVID, I think the hospices in the community have really quickly learned how to meet their needs using different resources such as their virtual visits and telephone visits.
Okay, and so these next couple of questions that I have as we're starting, as we're coming into a close, I would like all three of you all to share a little bit with us today. starting with you, Trayvon, how do you keep the family in the loop regarding the care?
Okay, so that's a great question. So I like to definitely stay in touch with the families by calling the families, giving them updates about what's going on, and be in regular contact with the family. Definitely, if I notice something when I'm at the visit, and also about decline. So one thing I like to start teaching from the beginning is like the signs and symptoms of decline.
Mhm.
So just to kind of prepare them so that it helps to assist with the hospice nurses also. So we stay in good collaboration. And so that's a good way to keep in touch with the families and kind of just prepare them for what's to come. And as a social worker, that kind of helps because a lot of time we're doing the emotional part and the support. And so just keeping in touch. So sometimes you'll be at the visit and you'll see things and they'll say, oh, you did tell me that, or I do remember that.
Mm-hmm.
So, yeah.
Okay. And Catherine and Atande, you all together from managing a team with 5 disciplines, how do you make sure that families are kept in the loop? I know that you all will have supervisory visits, or you may just check in and different things like that with the family and with the teams through team meetings. So share a little bit about that with us. Catherine?
Sure. So when it comes to the patients and families, we recognize in hospice that the families are a priority. They need to be updated. They need the education and the skills. We know that we're a specialized field, and we know that we have to be the ones to teach and support families. Otherwise, why would we be there? So we make sure during our meetings, we have meetings with the medical director, social workers, chaplains, and nurses every other week. And in those times, we make sure that the plan of care is up to date, and we make sure and confirm that the different disciplines are calling and contacting the families. We also are available for families and patients to call directly. And like you said, we do our supervisory visits, and we go out to the different facilities and assisted livings and check in and just say hello and get to really know the staffs ourselves so that we're well prepared for the needs.
Okay. And Atande, share with us some of the things that you do. I know you provided educational workshops and different things like that. So share with us from a managerial perspective how you're able to demonstrate keeping families in the loops through education as well.
One of the things that we stand out for is effective collaboration and effective teaching here at Montgomery and Prince George's Hospice. So it doesn't matter where our patient is, be it in a facility, be it in a home. You know, the family is a very, very important part of the patient's care. So we do make sure that we're teaching the families alongside we're teaching the facilities, so that all of this information is, everybody's hearing the same thing. Some families, based on, the care that we've provided for so many years, some families have a spokesperson. They have that person where they want you to give, all that information to. Most of the time is a healthcare power of attorney. Sometimes it's somebody else. So we try to channel our information, through that person, if it's appropriate for that family, remembering that every family is different and every family has a different need. If that criteria fits that family, then we try to channel the information through that person. We also do a lot of work to teach the caregivers, the people who are at the bedside with the families or with the patients, so that whatever it is, like however the patient changes, we're making sure that we're equipping the primary caregiver who's at the bedside to be able to teach and respond to the patient's needs as we observe decline. So teaching is really, it's a really important part of this work that we do, to be able to make sure that everybody understands the hospice journey, everybody understands the patient's decline, and everybody knows what to expect next.
That is great. That is great information from all of you. So as we're now coming to a close, I think we was able to give well-rounded information in this little bit of time, and very helpful in touch bases on just about everything. And this is something that we can continue to do as time goes on, or maybe even turn it into a series. So at this time, and as we close, I'd like to thank Atande, Catherine, and Trayvon. Thank you all very much, and enjoy the rest of your day.
Thank you.
Thank you.